Alrighty. Quick announcement before we get started. If you guys are not receiving emails from pre-health shadowing and you are signed up with an account and you want to get updates about when our next shadowing sessions are going to be, please be sure to follow these steps. You're going to go into your emails, check your spam, check your junk, find pre-health shadowing. Once you find the email, wherever it decided to end up, go ahead and mark that as important. When you mark that as important, you're telling the computer system that this is something you want to see in your main inbox. Another thing that you should do is save pre-health shadowing as a contact in your email, and hopefully this will resolve that issue. So you'll start getting pre-health shadowing emails to your inbox. This is a great opportunity for you guys to get exclusive different deals that we have going on. Sometimes we have free opportunities or learning spaces for you guys that we can share. So definitely be sure to subscribe to pre-health shadowing emails to never miss a session and to get exclusive deals. Just a quick update. We currently now have closed captions for all of our sessions to accommodate for students with hearing disabilities. So thank you for requesting that for those of you who contacted us about this. I'm really excited to present this to you guys. So we are now able to reach a wider student base of different people with different abilities. Our next announcement is that our website has been going down recently. We've been having frequent errors, and this is due to the load of people that we have on our website. So recently we've been gaining lots of students, which is super duper great, and we're very excited that you guys are using pre-health shadowing as a way to get pre-health virtual shadowing hours. The only thing is we have to raise money now so that we can keep our program alive. So we stand by keeping pre-health shadowing 100% free for all students. This is our mission for accessible and flexible learning as we work to fight against inequities in health education and to promote diversity in the various health fields. So we could be charging, $1 per session. That would be more than enough to cover the costs that we need. But unfortunately, we don't want to do that. We want to keep pre-health shadowing free for everybody. So all that we're asking is that you pull out your phone right now and you scan your computer screen. This will take you to the pre-health shadowing GoFundMe page. If you or your family are able to donate, we appreciate anything you guys can provide. If you are not able to donate, we ask that you share this with 5 people. So please do your part in helping keep this program alive. We appreciate any donations, $1, $5, anything you guys can provide will help keep our program alive and help give opportunities to people who might not have that opportunity in other situations. Last announcement really quickly, for those of you who are attending our, go ahead and post pre-health shadowing. You guys can tag us for an opportunity to be posted on our official page. Dr. Brittany Inerfeld is going to be giving her shadowing session today. And so go ahead and share with all of your friends, all of your pre-health friends, anybody who's interested, give us a shout out. You guys will definitely get the opportunity to get reposted. Don't forget to tag us. And my last announcement is take good notes, because at the end of this, you guys can receive your verifiable virtual shadowing hours by taking a short assessment. That's not meant to be difficult, but it's just meant to show that you were actively participating and paying attention during the entirety of this shadowing session. So be sure that you guys are taking notes and asking good questions. And without further ado, I welcome to you our presenter for today, Dr. Brittany Inerfeld. Welcome.
Thank you. Hi, everybody. Let me pull up the screen real quick. And can you guys hear me okay? Okay, awesome. So let's turn this in presentation mode. Okay, so I just wanted today to be super informal and kind of show you what PT is really about. I don't know if any of you guys are interested in PT, but if not, maybe it'll pique your interest and send you that way. If you think of questions as we go, I think that you can just stick them in the group chat and I'll try my best to answer them at the end. Yeah, so let's get into it. Okay, So my name is Brittany Inerfeld, and I'm my doctorate in physical therapy. I graduated 2 years ago, so I got a little taste of life before the pandemic, and then here we are today, and everything's a little bit different. I work in an outpatient orthopedic facility, and right now we're finally getting back into regular hours. So I just came from work. I'm actually still at the clinic. A couple of things to expect with this presentation. I'm going to talk about myself, tell you guys about physical therapy, why I chose it as my career path, kind of what it looks like to become a doctorate in physical therapy, and a standard workday, what that looks like, do a couple of case studies, and then leave some time for the Q&A at the end. So a little bit about me. I was born in Long Island, New York, but I was raised in Miami, Florida. I graduated with my Bachelor of Science in Exercise Science from Florida State University, so go Noles. And I got my doctorate degree at Nova Southeastern University in Fort Lauderdale. And definitely huge transition or huge difference between undergrad and graduate school. So if you guys have questions about that, I'd love to spend some time answering that after, but not to be super boring now. You can see in the bottom left is the love of my life. So that's my dog Ryder. I had to find a way to throw her into the presentation somehow. And I got her actually during PT school when stress levels were super high, and probably either the worst or the best time to get a dog. I'm not really sure, but either way, there she is. And some things about me just in general, I'm super into fitness. I love working out. I love to travel. That top right picture is actually from an internship that I did abroad. So I'll talk a little bit about the opportunities that you can get in PT school. All right, so what is physical therapy? Physical therapy in most other countries, they say physiotherapy, so it's the same thing, they're interchangeable. It's the practice of movement analysis, and you're constantly looking for limitations or movement dysfunction that's affecting somebody's quality of life. So the biggest part of our job is just being a movement expert. And that's every part of movement, whether it's functional, something like getting out of bed and getting ready in the morning, or something that they do for recreation, like sport or fun. We use a combination of different things like therapeutic exercise, manual therapy, manipulations, and a bunch of other interventions that help with tissue healing or prevention of injury. I would say more recently, physical therapy has gone into the prevention field. Typically, that's not common with insurance that they'll cover it, but it's becoming more known now that it's really important to nip those problems in the bud before they become an issue. Some of the things with manual therapy that we do, even though manipulations is a word that people associate with chiropractics, we do manipulations in order to improve joint range of motion, which is just how well you're able to move different parts of your body. We use different modalities. If you're familiar with things like electrical stimulation or ultrasound, in the outpatient orthopedic world, those are more for pain relief and like inflammation. And then sometimes in other settings, they'll use them for different things. So I will talk about other settings a little bit, but obviously my expertise and all my experience is going to come from the outpatient setting. We use a combination of all of those different things in each session, each plan of care. So when you go through physical therapy school, you learn all those different aspects of treatment and care. You learn how to do manual interventions, you learn how to do manipulations, you learn about therapeutic exercise. You obviously learn about the tissue healing process and the way that different injuries recover and how long those take. But I will say that everything that you, or that I at least received and skill, has come in the clinic outside of school. So they give you the bare minimum to kind of get through, and then you learn everything when you're hands-on. You've probably seen a lot of other manual therapy interventions just on people's bodies. We use things like cupping or kinesiotaping, and that helps to improve range of motion. It can help with pain relief. It can help with improved blood flow. So if you see like Michael Phelps in the Olympics back in the day, he had those big red welts kind of on his back in little circles. Those are from cupping interventions, and we use that. The kinesiotaping is that very colorful tape that you'll see on people's bodies, sometimes in way too many places and definitely not necessary. But in here, we try to use it just on one joint across the body. We use things like the therapy guns, which are really big right now, but we use them in the clinic as well. And then with manual therapy, we also do passive movement and help people get through post-op or something. If they're not able to actually move their own arm or leg on their own, then we'll help do it for them. There's a bunch of different specialties that go with physical therapy. So very similar to when you go to med school and then you choose what you want to specialize in. Physical therapy has that now as an option. I think within the next 10 years or so, it'll be more of a mandatory thing. Like you have to go to a residency. For now, you can choose whether you want to specialize, but no matter what, you're going to graduate with your doctorate in physical therapy and you are just a general doctor, but a general doctor of physical therapy. So if you choose to go into something like pediatrics, which is more specific, then you can maybe get a job just going straight into it. Or if you want to be a little bit higher on the competitive side, then you can go and do your residency and then you can get a year of pediatric experience before you go and get your first job. So some of the specialties, these are the main ones. There's cardiopulm, pediatrics, geriatrics, neuro, orthopedic, sports, women's health, and telehealth, which is definitely on the newer side. Pediatrics is going to be working with kids typically under the age of 18. Geriatrics is going to be older, elderly adults. And neuro is going to be brain and spinal cord. Orthopedic, which is where I am, it can include sports related injuries and it can include pediatrics and it can include geriatrics. And I definitely have neuro patients as well. But generally in an outpatient orthopedic setting, it's not going to be something so specific or so such a safety issue that we need specific equipment. So most people can get here on their own or with someone helping them, but they're physically able to get in and out of their car and into the clinic. Sports physical therapy is also really common, really competitive. If you have an interest in working with a certain team, you can be, physical therapist for a certain team. You can do sports physical therapy at different schools, at different colleges. I'm pretty sure most colleges have their own PT. There's also women's health, which includes men's health. It's a terrible title, but that can be stuff with like pelvic floor dysfunction and anything like that. And like I said, telehealth definitely booming now. I picked that up during COVID, so I'll talk about some of the pros and cons and the struggles with that a little bit later. But the other thing I want to touch on is the difference between inpatient versus outpatient. So if you're not familiar with those words, inpatient, just like it sounds, it's where you're going to be somewhere that somebody is living or staying for a longer period of time. So when someone's in a skilled nursing facility or a hospital, they're not in and out in a day. They stay there for a couple of days. Some of them live there if it's a skilled nursing facility. So any treatment that you do in those kind of settings is going to be an inpatient setting. And then outpatient, like I mentioned before, is just that people are coming to your clinic. They maybe spend an hour, 2 hours tops there, and then they go home or they go wherever they're from and they do their own thing. If you do choose to follow up with a residency after PT school, it is kind of like taking another year of school. So you have a combination of hands-on clinic experience with someone who's an expert in that field, but then you're also learning more specific stuff on the side. Each school does it a little bit differently. For Nova, we didn't get to choose electives. We took classes in all of these different specialties, and you kind of get a taste of each one, but then you can choose to obviously go further and learn a lot more with your residency. I know some schools like University of Miami, they do where you can pick a like specific kind of elective that you want. So if you're interested in pediatrics, you can take an extra pediatrics. We take it no matter what. So we do get a little bit of everything in the Nova curriculum. And you're able to work, like I said, in all of those settings without going into a residency afterwards, but you're just a little bit more competitive. If I'm applying for a job as a pediatric physical therapist, but I didn't spend that extra year with that extra experience, and somebody who else wants the job did get their residency and did get that extra experience, then they're more than likely going to get the job over you at this point in time. If it changes in the next couple of years, it'll be mandatory where after school, you're required to go through your residency, and then it'll be a little bit similar to how med school runs. Okay, so different kind of practice settings, and that goes in a little bit with inpatient versus outpatient settings. You can go into privately owned clinics, which is what I am in. There's outpatient clinics, which is the same thing. So I'm an outpatient, but a privately owned. There's some chain clinics. So I'm sure you've seen in your area, there's probably something like a Cora or something where there's multiple locations under the same name, some of them state to state. There's different health and wellness clinics. So if there's a rehab center where, there's everything included, like acupuncture or something like that, um, rehab hospitals, skilled nursing facilities, you can go into people's homes if that's something that you're interested in. You can work in schools, hospices, fitness centers, and sports training facilities. So, a lot of times with pediatrics, especially with physical and occupational therapy, if you do work in pediatrics, you tend to work in schools and you work with kids doing things that they're not able to get through the school day. So, if they have a hard time sitting for long periods of class or getting from class to class, then you're going to go into the school and you're going to try and get them more functional. Obviously, we see pediatrics in outpatient orthopedic because they'll come in with like an injury if they had a fall, a broken bone, post-operative, then we can still see younger kids, but the general pediatric physical therapy is going to be in school working with things like that. Okay. Some of the reasons why I got into PT. A lot of people have this crazy first experience where, they hurt themselves, they got injured, it was amazing, their PT changed their life. I did not have that at all. I had no injuries, I had no nothing. I knew I wanted to work in the health and wellness kind of world industry, but I didn't know what I wanted to do. So I was always interested in exercise and health and wellness, but I didn't really know going into college even that was something I was into. I walked in day one, I chose exercise science as my major, and I just kind of got lucky. That being said, because I wasn't sure exactly which route I wanted to go, I did take a lot of the prerequisite courses for med school because that was definitely something that I was considering. I tried a little bit of everything. I thought I wanted to be an orthodontist. So I set up a dental clinic in Nicaragua with the pre-dental team at Florida State. And it was honestly awful. Like, kudos to all the dentists that do it, but my back hurt. I did not like bending over all day. I didn't like being in people's mouths. I didn't think it would gross me out, but then it did when I got there. So it was an interesting experience. The biggest tip that I can say going forward is definitely make sure that you practice, shadow, live a day in the life of whatever you're thinking about doing. Because I'm not kidding, I thought I was going to be an orthodontist for years. And that 1 week setting up a dental clinic changed my life. So if I hadn't done that and I had applied to dental school, I kind of would have been in it for the long haul and stuck it out. And I don't know if it would have worked out just as well as this did. I also thought that I wanted to go to med school. So I was a scribe in the ER in Tallahassee. And it was just an awful situation of both things. I worked 9 p.m. to 6 a.m. shifts, and I'm not a night person. So the combination of that and just not loving the hospital setting made me realize that I didn't want to go into medicine. I was working overnight at a hospital at like 3 a.m. I think it was, and I found a job application or a job request on Craigslist, very professional, and I submitted my application at 3 a.m. I got off at 6. They emailed me at 6:30 and asked me to come in for an interview, and this was as an exercise technician. I went straight from work, crushed my interview, and it probably took me 48 hours to realize that I wanted to be a physical therapist. So, I tried all those other things. Definitely make sure that you try it and you experience it, and you'll figure out what you like quicker than you think you will. Because I worked in that ER for 2 or 3 months and I hated every day. And it was such a flipped switch when I got into the PT clinic. One of the things that's super unique to PT in the health world is that we do get to spend a lot of time with our patients. It's not very traditional in most fields. You go see your dentist, once every 6 months. Hopefully you're not in the ER very often. And even your GP, if you see them year after year, you don't really build the relationship that you do get to build in physical therapy. We traditionally, especially in outpatient, see patients for up to an hour, 2 to 3 times a week. So you'd be amazed at how much you can learn about somebody and their family and their everything in those hour sessions. We do get really close to our patients, which is a pro and a con. Getting really close to your patient makes you bond with them, and then it's really difficult to say goodbye at the end because they do become part of your family. But it is really awesome because you get to build that bond, that relationship, and I think that's super important for the therapeutic process in general. It's also a huge partnership. If you go into something where it's more one-sided, let's go back to dental, you're in the chair and the dentist is doing their job on you, and you don't really have to do anything. You just kind of to sit there. They usually prop your mouth open. You really don't have to do much. With physical therapy, it's a two-way street. So as much as I'm willing to put in, the patient has to put in as well. And it is really cool to get that reciprocal environment with your job, because you don't just feel like, oh, I'm putting in all of this and nothing's coming out of it. If you sit there and you give them 8 hours of your time and you do all this stuff, but they're doing nothing on the side at home or on their own, then they're not going to have successful outcomes. So I do kind of like that it holds them a little bit more liable. Some of the PT prereqs are very general for anything in the health fields. You're going to have anatomy with the lab, physiology with the lab, bio 1, bio 2, Gen Chem 2 with the lab, physics 1 and 2, psych and statistics. That is the minimum, and that's kind of just the most common. I definitely recommend that you go and look at different schools. If you're thinking about a certain school, they might have a specific requirement. So you want to go on and see if there's something that you're missing in those basic prereqs to make sure that you have it covered. You also definitely don't have to have a health background. We had English majors and everything like that in our PT program. So the only thing to be mindful of if you aren't in a health undergraduate major is that you have to make sure that you hit these other prereq classes, just so you don't have to take an off year unless that's something you want to do, and take those classes on your own time. I was super fortunate and it worked out because I wasn't sure what I wanted to do. So I did take things like orgo and calculus because you needed those for like dental and med school. And it just turned out that extra things. So it's a two-way street. If you take those and you do well in them, then great, you have them just in case no matter what. If you take them and you don't do well and then you change your mind, then they put a damper on your GPA. So something to consider if you are going to take it, just to have it under your belt, that you make sure that you invest the time that you need in the courses so that you do get good grades, because your GPA obviously does matter in the long run. And okay, some stuff about getting into PT school is it's a little bit different now than it used to be, because now it is a doctorate degree. So it's 3 years. You have to complete all your prerequisite courses that I just talked about on the last slide. You'll take your GRE, and most schools require that you have hours in a PT clinic. So whether that's shadowing or volunteering or working as an exercise technician, anything like that, they all work as getting those hands-on hours or those shadowing hours. There's some schools that don't require any hours, but it goes into the same thing as like a residency and getting a job later on. If there's somebody who's competing for your spot and they don't have any hours, but you have 100 hours in the clinic, more than likely they're going to take somebody who already knows that they've experienced what it's like to be in a physical therapy world and that they already know what they want to do, so that they don't waste the spot. If you're not so great with interviews or you have a fear of public speaking, you definitely want to prepare for those interviews. Same thing like most other medical programs. I had a terrible fear of public speaking my entire life. And one way that I got over it was I started teaching spinning when I was in undergrad. So I know that's a very random thing to think about, but if you do have issues with public speaking, spinning is typically in a dark room, which is amazing because nobody can see you. And there's very loud music, so almost nobody cares what you're saying anyways. And you get your endorphins going because you're exercising and you're working out. So I always recommend that if you're into fitness or anything like that, and you can try getting out of your comfort zone in that way, it definitely helped branch me out and get over that fear. So random little tip. The road to your doctorate degree, like I said, it's going to be that 3-year program. So you have 2 years of didactic learning, which means that you're in the classroom. It's a combination of lecture and lab. Every school is going to be a little bit different, but typically you're going to have classes where you'll do the first half of lecture and then you'll do the hands-on part. So PT is also very cool in that we can see, touch, and feel a lot of the things that we learn. And I think that really helps with people who aren't just visual, aren't just audible learners. You get to kind of get that full experience. So we can hear something in lecture and then you can go and physically try it on your lab partner and see something work or see something change. You can feel a muscle contract. You can feel the stretch. You can feel what a joint feels like. And I do think that's a really cool part of the experience and just being in school. You'll have clinical internships throughout the curriculum. Every school, again, does it different. Nova, we start in our first year. We get a week-long internship in a SNF, which is a skilled nursing facility. And you'll have a couple of 4-week rotations throughout your clinical experience, typically at the end of each year. And I think the ones during your years, if I'm not confused, are 4 weeks at the end of the years, and then you'll have 1 full year of internships as your last year. So the clinical internships that go throughout your didactic learning, those are going to be your shorter term, and it's just getting your foot in the door. The last internships on your third and final year are a little bit more serious. In the beginning, they don't expect you to know anything because we're still in school. You typically haven't touched any real people. You haven't done anything except with your lab partners. So they don't expect that much out of you, but it is just a good opportunity to kind of, again, see where you're at. I think our class started with about 55 people, and we lost anywhere from 5 to 10 after the first clinical internship, because that same thing that happened to me trying to go into the dental field, you experience it, you see what it's like, and then you realize like, oh, this isn't for me. So that same thing could happen. That's why you really just want to make sure that you don't invest a year of your time, your money, and your everything else before you know what you really want to get into. The year of internships, they try to include a couple of different components so that you can experience the different specialties. I think a lot of times, and I was one of them, that when you think of PT, you always think of that outpatient orthopedic. You think of somebody doing exercises with you and in the setting where I'm in, and that's what most people think that they want to do. And fortunately, when you get the experience in other settings, which they try to force you into, a lot of times you're pleasantly surprised with how much you like something that you wouldn't have even known about. I mean, I didn't even know that PTs were in the hospital or were in a hospital setting when I was pre-PT school. And then afterwards you find out like, oh, I didn't even know all the things that you could do that aren't just in a gym environment. So it is really cool. It's all very different. My suggestion is just to be very open-minded. And if you don't like it, it's only just a short internship, so you're not stuck with it. And the application for residency afterwards is optional. Then you have graduation, where you don't take your boards until a couple months after graduation. Our boards exam is the MPTE. You can start working on a temp license after graduation. So I was one of the few. I graduated on a Friday, and by Monday, I was already at work, and I just kind of balanced studying for the boards exam and practicing with my temp license. The thing with internships also that I should note on is you want to make sure that you're doing your internships somewhere where you possibly want to work. Because let's say you are really bad at interviews, right? If you go in for a job interview and they're not really a fan in that first 5 minutes, then maybe you didn't get the job. But if you have 3 months, or it's usually about 8 to 10 weeks, to impress somebody with your work ethic, with your personality, with everything else during that internship, then it gives you the opportunity to be on the back burner for a job. So I did a little of that and a little not of that. I did my first rotation out of state in Texas, and that was just to get the experience of 3 months in another state. I loved it. And then my second internship was at the clinic where I work now. And that's why I always say it's a really good idea to pick at least one, if not two places where you could consider seeing yourself working. And right before I finished my internship, I knew that I wanted to work here, and I talked with the owner, and it was just a mutual feeling. So it worked out really well, and I'm super happy to be here. And my third internship, I did abroad in Italy. So my only regret probably in undergrad was that I didn't study abroad, and I thought I missed out forever. But a lot of schools, or at least Nova, I don't know about a lot, but a couple of schools offer abroad internships, which is a very cool experience. You get to see what your PT career looks like in another country, which is very different on so many levels because the insurance system is different, the quality of life is different. There, for example, when you have a typical work day, they start at like 9 and they end at 3:30 with about an hour and a half break. And you're never going to find that in the US, but it was a different experience, and it was super, super cool. So if that's something that you're interested in, making sure to take the time and looking at the schools that do offer that. When you work with your temp license, it is obviously it's temporary. And then assuming that you pass your boards, you can just continue to go and practice with your regular license after that. And a typical workday in an outpatient orthopedic setting, everybody's going to be a little bit different. And especially in other settings, I know they do not look like this at all, but this is just an experience for what my day typically looks like. I work 7 to 5 on most days. Treatment sessions last about an hour, and we try to do one patient an hour. Sometimes we see two, depending on the patient and the day. Each patient interaction gets its own SOAP note. So I'm sure you've heard that from the other health profession fields. Subjective, objective, assessment, and plan. And every day is going to be a little bit different right now because some days we have normal regular hours, then COVID, some days we're super slow. So this whole thing has kind of put us into a little bit of chaos. Obviously, this is a recent picture because we're masked up and we weren't always masked up. And that's just a picture of me doing some cupping. I don't think you can see the cup that well, but if you're familiar with that modality, then you'll just recognize it underneath the hand. We also have to add a little bit more time in for all the cleaning that we've had to do with COVID. So that takes a little bit longer. So our treatment sessions have probably gone down to closer to that 50, 55 minutes, just because we do have to clean everything super religiously and it takes a lot more time than you would notice. Now that we have something called direct access, I don't know if you're familiar with that term, but it just means that a patient is able to come to their physical therapist first before going to their doctor. So back in the day, you had to go to a doctor, you had to get a referral and then a prescription for physical therapy that said, eval and treat this part of the body. Now we can see them for up to 30 days, depending on insurance. And with that comes a lot more responsibility. So that's why our curriculum has gotten expanded a little bit more. And we are required to take like integumentary and other systems. And we learn a lot about other parts of the body because you do have to be able to recognize those red flags or anything that might come about where you would have to refer them to someone else. You have to recognize what's in your scope of practice versus what's outside your scope of practice. I think that's on for that. Okay. So we'll go into a couple of case studies, and I just picked 3 that show kind of a difference of how wide of a range of things that we see here. So this first one, 54-year-old female, status post, right total knee arthroplasty, and that's what all those little abbreviations for. So when you get a total knee replacement, you can do a hemi, which is just half, or you can do a total, which is the full thing, like in that picture right there. And that means that they're going to go above and below in the joint, and they're going to put pieces into both parts, so total. And this patient comes in using a front-wheeled rolling walker. They have decreased weight bearing on their right lower extremity, increased swelling, mild erythema surrounding the incision site, which just means some redness. And those are things that you're 100% of the time going to see after a total knee replacement. So with total knee replacements, especially nowadays, I talked a little bit about prehab. The outcomes are a lot more successful with a lot less pain if a patient can come in prior to surgery and work on their knee. So it sounds silly because you know that you're never going to get them. Some people's knees aren't salvageable. They know that they're going to get surgery. Their doctor has told them, they've talked about it. But if we can get as much movement in the knee as possible going into surgery, then that's going to make the recovery after surgery that much better, that much easier. If you've been holding on to your knee without bending or straightening it and you've been protecting it for months and months, then it's going to be that much stiffer in that surrounding tissue when you come off the table. So I think that, again, that's becoming a little bit more common, much more recently. It was never a thing to do prehab before surgery, but now they're seeing how successful the outcomes can be. So it really does help. It helps the surgeon, it helps the patient, and it's good for everyone involved. I thought we'd talk about some of the things with the initial evaluation. So what we look at, the subjective reports, I'm going to ask them about their pain level, 0 out of 10. After post-op, they're going to be very high. Everything is uncomfortable. Part of our job is calming them down, and it's a very emotional experience. There's a lot of trauma to the tissue. It's scary. Now it's even scarier with everything going on with COVID. But even though it sounds like a silly thing, like, oh, make them feel good, but it is really important that they feel comfortable in your clinic and comfortable in your care, so that they can calm their nervous system down and realize what's going on with their body. A big thing that we notice too is a denial to connect with your replacement. So it is important that they understand that this now component in their body, even though it's a foreign object, is now their knee. And sometimes that takes some getting used to, because it is a little weird to think about if you've never had a foreign object implanted into your body and all of a sudden now this titanium something is your new knee. Objective measures that we look at, which just means things that you can measure before, during, and after their treatment session to note progress. So subjective comes from them, objective comes from the therapist. And when we do range of motion measurements, we're looking at how much they're bending, in this case, bending the knee, straightening the knee. We look at things like their ability to put weight onto that leg. Are they able to stand full weight bearing, 50%, which means both feet are on the floor, but they're even? Is it less than that? Are they shifting, in this case, shifting to the left foot and not able to put 50% onto the right? Those are all things that are super important to look at. We also want to make sure that there's nothing to be concerned with post-operatively. So there's no signs of infection, no signs of DVT, anything that we would have to call the doctor or refer out for. And assessment and goals, we're always going to be looking at things that are realistic and functional. So if somebody in their 54 has never ran, never did anything in the gym, not athletic, overweight, a lot of comorbidities, and they tell you, you know, I want to get this new knee and run a marathon, is it impossible? No, but it's not going to be a therapy goal. So when we talk about therapy goals, we're thinking 6 to 8 weeks, depending on the injury, and where can we get you in that 6 to 8 weeks. That doesn't mean that you stop doing everything related to exercise and health and wellness after you're done, but you don't need to see us all the way until your marathon. You just need to see us until you're comfortable with your home program and you get your range of motion and your strength and your stability back. Again, with total knee replacement, in this case, something that's super important is getting back to walking without a device, if that's how they were prior to their either intense knee pain or prior to surgery. So there's going to be a progression from using a walker. Sometimes they go straight from walker to nothing. Sometimes we have to get from walker to crutch to cane to nothing. So it's different person to person. It has a lot to do with how much damage was done to the knee prior to surgery. If they've been dealing with that for a really long time, and there's a lot of other things going on in the body, then it's going to take a little bit longer to heal. But if they had the surgery and they had they had PT as like prehab and they're moving pretty good, then their recovery is going to be that much faster. The plan of care is something that the doctor will usually write on the script, and then it's something we take in mind, but we also talk with the patient. So depending on their schedule, you know, are they super busy and they're not able to come in that 2 to 3 times a week? If they're only coming in once a week, then we might need to see them for a little bit longer. Also important that they're super compliant with their home exercise program and doing their own part, because that two-way street comes right back into it. So overall, goals need to be realistic, plan of care needs to be realistic, and then there needs to be an understanding between you and your patient so they know what to expect, because some people think that they can get better in one session and some people think that they can be PT lifers, and unfortunately with the insurance world, that's just not the way it works. You're not going to be able to justify insurance if you can't prove that there is some kind of progress and if you can't show that it is functional or returning them back to the way that they were before. Okay, so second case study. So this is a totally different kind of situation, so I wanted to try and incorporate the different patients that we see. This was a 16-year-old female with multidirectional instability of the shoulder. It could be considered a pediatric case, but I saw her in outpatient orthopedic, so it works both ways. She had no pain at rest, only pain with activities like swimming or sailing, and then sleeping when she laid on that same side shoulder. So with instability of the shoulder, you've got your ball and socket, which is kind of how your shoulder fits in that joint capsule. And it should be pretty snug. So when you lift your arm up, it's not like your glenohumeral joint is kind of wiggling all over the place. You've got a snug fit with your rotator cuff. If something happens where you naturally just have a lot of laxity in your joints, or something traumatic where that shoulder dislocates or even subluxes, which means it goes back into place on its own, you don't have to go get it relocated back into your body. Subluxations happen, they pop out, they pop back in. After that subluxation, you are more likely to have another subluxation or a dislocation, because now there's that laxity in the joints that surround the tissue, in the tissue that surrounds the joints. So things that we look at with instability is we actually feel the joint itself. So I get my hand on that glenohumeral joint and see, does it feel like there's a lot of movement in all the different directions? And a lot of times you do have to double check what comes after the prescription, because somebody can write something on there, they can write multidirectional instability, but the truth is, in the healthcare model that we have now, the doctors who are writing the referrals just don't have as much time to spend with their patients as we do. So you have to take it with a grain of salt, really do your own assessment, listen to what you're getting on your referral sheet, but don't just think that, oh, this says multidirectional instability, so it must be multidirectional instability. Make sure that you're doing your own assessment. The initial evaluation, things that we look at, again, subjective reports. So what's her pain level when she's doing those activities? Is it something like a 1 or a 2 where she feels it, but it's not unbearable? Or is it something where it's 9 out of 10, it's excruciating? In this particular case, with things like the swimming or the sailing, where she was being more active, she had about 30 minutes where she was able to tolerate activity. And then after that 30 minutes, it was unbearable. She had to stop. Sleeping on the shoulder was an issue some nights and not other nights. And it was unrelated to whether or not she was active and doing the swimming or the sailing that day. So it just kind of came and went with no rhyme or reason. So the objective measures that we look at that glenohumeral joint, see how it's moving, see if it feels like there's hyperlaxity or extra movement. We look at strength of the shoulder, the muscles that support the rotator cuff, see range of motion, how high are you able to raise the arm? Is there pain at any different level? For this particular case, every time she lifts the arm up overhead, she has pain starting at about 100 degrees, and then it just kind of maintains and stays the same all the way up to the top, but she does have full range of motion of the shoulder. It's just with pain. So then we do things like strengthen and stabilize the shoulder in that space and see if that helps to alleviate pain. In this case, it did. So just doing some manual overpressure in the different planes of the shoulder. Assessment is geared towards why we think that there's multidirectional instability. In this case, it was pretty straightforward because she does have a history of subluxation and general hyperlaxity in the body. Goals are to get back to activities like swimming or sailing, reducing the pain at worst to a 0 out of 10. And then we have some functional indexes that I didn't talk about before, but every part of the body typically has its own index. There's a back index, a neck index. So those are things that the patient can fill out. And even though it's subjective, it asks them a bunch of questions about their pain and how they think that they're moving and their ability to do certain things throughout the day. We do look at those at every couple of weeks to see if there's change, because even though we're measuring things, I can say, oh, her shoulder range of motion went from 100 to 130 degrees. That's great, but that means nothing to your patient. So seeing things like they were unable to do their hair without pain, but now they can, that's something that means a little bit more to them. So we try to use those things that are relatable so that they can feel successful with their progress as well. The plan of care in this case, the patient's a student, so her availability is more restricted than some others might be. We're only open certain days late, so I had to have her on the 2 days a week track for about 6 weeks, and things like kinesio tape, cupping, manual therapy to do that stability of the shoulder. All of those things were super, super helpful. Kinesio tape is something that I gave her for the long term to do like competitions with, because you can keep it on when you're swimming, you can keep it on when you're sailing, but I still focused on strengthening and stabilizing the shoulder without any kind of extra assistance, so that you have that as your crutch and your backup, but you still have the strength and stability in your shoulder where you need it. Third case study is 30-year-old male with headaches and neck pain for about 3 months. We see a lot of people who come in with headaches, and even though that doesn't seem like something you would see your physical therapist for, it does if they're cervicogenic in nature. Cervicogenic means coming from the neck. This particular patient works from home, spends most of his day sitting at the computer. And I know, especially as students, we get that. That's a lot of our life. So initial evaluation, subjective things that we ask: what's your pain level? Where are your headaches in location? Is it frontal? Do you feel like it's coming from the back of your head? Does it radiate anywhere beyond the neck? Does it go down into the shoulders? So sometimes neck pain can be just neck pain, and sometimes shoulder pain can be just shoulder pain. Sometimes your shoulder pain is coming from your neck and vice versa. So those are things that we kind of clear by looking at different movement patterns. If you have somebody who works from home, you also want to ask, what's their schedule like? Because if I worked from home, I would make sure that I'm getting up every hour, at least once an hour, and move my body around, getting on my foam roller, doing whatever I need, because I know that's something that my body craves and I know that it's good for me. Most people do not, and they sit down at 8, all of a sudden they realize it's 1 o'clock, it's lunchtime. Maybe they even don't get up from their desk for that, and then they sit down again and it's 5 o'clock and the day's over. So making sure that you are understanding your patient and your patient's lifestyle is really important when you're getting that subjective report. In this case, it was on that extreme end where sitting all day, not a lot of breaks, and pain usually started towards the first hour or two of work, and then it just stayed about the same. So it didn't get any worse, but it didn't really get any better. We have something called postural syndrome, which basically just means when you're sitting for a long time and you have even the best posture, those muscles and ligaments and everything that have been in a certain stuck position start to get uncomfortable. And that can cause pain in the mid back. It can work its way up the neck and ultimately lead to headaches if you have what we call like that tech neck, which is your forward head and rounded shoulder posture. So a lot of times nowadays, people are on their phones, people are on their computers for crazy extended periods of time. A cool little experiment that you guys can try later is if you take a hammer and something that has like a really heavy head, and you just hold it in your hand and you tilt it just a little bit forward, and you feel the weight of that hammer. So if the hammer head is all the way up here, and as you start to tilt forward, you'll feel how much heavier it gets just every time that it moves out of that frontal plane. And that's a good example of what it feels like when you are looking down at your phone all day. So your head is that really heavy head of the hammer, and your neck is that tiny little guy that's trying to support it. And every time your head is just that little bit more forward, you are putting a lot of stress and strain on your neck. So that's one of the things that we had to talk about with this individual in this case. Objective measures we look at are cervical range of motion, looking down, looking up, every direction, seeing if there's pain in anything like that, and if anything radiates either into the head causing headaches or radiates beyond the neck into the shoulders. In this case, again, it was pretty straightforward that the neck and headache pain was coming from posture related stuff and too long of sitting at work without getting enough movement, those poor posture abnormalities that are causing structures to pull on the head from the neck. Goals are lifestyle changes. Big part of physical therapy is that patient education. So we learn a lot in PT school, and you tend to forget what is common knowledge and what you learned. So for someone like myself, it seems obvious, get up, move around, move your thoracic spine, open up your chest, do things like that. Some people don't see that. So they're like, wow, I sit for 8 hours and it hurts and I don't know why, and don't sit for 8 hours. So just kind of getting on your patient's level and making sure that they understand the importance of the exercises you're giving them so that they're actually more likely to do it. Because if I give you a bunch of exercises and I tell you like, do this for this and this for this, but you have no connection to it, then more than likely you're not going to have successful outcomes. You want to explain a little bit of the anatomy behind why you're giving them what you're giving them, and talk to them about what changes it's going to make in their body so that they can feel better overall. Plan of care in this case was a lot shorter because there wasn't anything specific that needed to heal. It was more lifestyle changes. So plan of care was just once a week for 4 weeks. And in those 4 weeks, we incorporated things like suboccipital release, coming right underneath the head and releasing those muscles, because that's very common with cervicogenic headaches. With that, we also can teach how to do those things at home so that when you don't have our hands, you are able to replicate the same kind of experience on your own. And that's another thing that is really important, so that your patients don't rely on you as a physical therapist and think, oh my God, when I'm discharged, I physically can't live without you. We try to find ways to replicate the things that we do with manual therapy the same way at home. So even though, of course, nothing's going to be as good as somebody else's specific hands-on treatment, it at least fills in the gaps and keeps them in the maintenance phase. Okay, so the big topic I thought I would address are some changes that we've seen with COVID-19. There's definitely been an increased interest in telephysical therapy, which I've always thought about, and I think a lot of people have thought about, but we got a kick in the butt and we picked it up during COVID. So I started doing that in the beginning back in March, when everything got a little bit crazy. We started offering free sessions at first because we didn't really know what we were doing. It is a totally new world to not be able to get your hands on a patient, to be looking at them from the angle that they set up their camera. That's definitely one of the trickier parts, is if you have older patients, their tech savviness maybe isn't that great. Not that mine's amazing, but some of them will put their camera and, you'll be looking at like the top of their head for the first 30 minutes, then you tell them to lower it and you're looking at a foot. So it is really tricky to make sure that you're able to see the entire body. The other thing is it's crazy what a little bit of an angle will do. So if somebody has their camera shift a little bit to the right and I'm looking at you, what I think is straight on, it'll look like one shoulder is elevated or they're leaning or shifted a certain way. And it's very hard to differentiate if the reason is because of the camera angle or if the reason is because they actually have some kind of postural something going on that you want to address. Nowadays in the clinic, we've had a really unsteady caseload. Like I said, there's just fluctuations. 1 week, it almost seems like we're back to normal. Everybody's coming in, everybody's fine. And then the next week, everybody gets spooked and they cancel their appointments and it goes up and down. And that's kind of been happening a lot lately. And I think that's probably in almost everybody's job everywhere because there is so much uncertainty right now. But that does make it tricky on us because if we have something like a plan set in mind with, I'm going to see you 3 times a week for 4 weeks, and this is what we're going to do Monday, this is what we're going to do Wednesday, this is going to do what we're going to do Friday, but then they cancel Wednesday, Friday, you don't see them again for another 2 weeks. That's a really big gap that you're not able to continue with your plan of care. If it's post-op, that's obviously a huge concern because there are a lot of things that you have to make sure that you get done in the beginning of post-op care. But even if it's not, even if it's just your low back or your general shoulder pain, you typically give a home exercise program to keep up with in the interim, but it's anywhere from 3 to 5 exercises. It's not really a lot. It's just to keep the momentum going in the off times when they're not in the clinic. So then if you incorporate those 3 to 5 exercises in between, it makes your success like way better, but it's not enough to supplement those 2 weeks of not coming into the clinic. Before a patient gets discharged, we'll give them an updated program, and that'll be a little bit more all-inclusive. That would be a more followable program that you can take with you after for discharge. We did have to limit the amount of people in the gym. So therapists have staggered schedules right now. Some of us work earlier in the morning and then others later at night, just so we have less people in the gym for our safety, for their safety, and also just to be more comfortable. Because even if you notice in places where you're spread 6 feet apart, if you notice that a place is really crowded, it can make you uncomfortable. Those stress levels are going to take their impact on patients and on their bodies. So we typically hold on to a lot of stress in our muscles, and our shoulders and everything will tense up. If you're trying to get somebody to relax and move their body a certain way, but they can't because their brain's going 1,000 miles an hour about, this person's too close to me or this is happening and I can't, then their success with therapy is also going to be affected. Masks are something that we've never had to deal with, and they do impact breathing, especially with patients that are immunocompromised. So we have some younger kids or even adults that are asthmatic, and now you're asking them, maybe they're deconditioned in addition to that, and they're overweight, all those things combined. And now you're asking them to breathe with a mask on and do exercises like they've never done before. So that's something that's been really tricky that we've had to work with. Sometimes we'll have to take them back into a private room just so they can catch some air and be in an isolated environment. But it does make things a lot more hot. It does make things a lot less comfortable. And it's harder to understand your patients, which is probably one of the biggest things I think in the outpatient setting. You get a little bit of a muffled tone with a mask on, and it goes both ways. Their muffled sounds that I'm trying to understand on eval day, and then they can't understand me, and it can get a little frustrating. And when someone's in a lot of pain, they are a totally different person. So on top of that, add the frustration of not being able to hear you, having loud noises in the gym. There's just a lot that can go on day one that can screw up your day. And I think that's pretty much it for the specific changes related to COVID. If you guys have any other questions about that, I can definitely answer. And then back to the telephysical therapy, I talked about disadvantages and things with the camera and technical difficulties. Maybe the internet goes out, things like that. But some of the good that came out of it is, one, we can see people during their work schedule, and it's a little bit easier if they have an hour lunch break. Now they don't have to worry about the travel and transit time and then waiting in the clinic, traffic, all those things, getting back to work. They can literally start the lunch break at 1. I can turn my computer on at 1 and I can see them from 1 to 1:30 or 1 to 2, depending on what it is. So it does give the work environment a lot more flexibility to come in for physical therapy. It also is a way for people to do it if they're traveling. It has to be in your state. Right now, you can't treat out of state. But if somebody from Miami is traveling to Orlando and they're going to be there for a week or 2 weeks, whatever it is, I can still follow up with them in the interim and do their telehealth physical therapy, which is pretty awesome. We can also get into people's houses. So now, you have difficulty with stairs at home and it's the stairs that you use every day to get into your bedroom. Now you can physically put me into your house on your computer, obviously, and you can show me your stairs and I can show you or watch you going up the stairs. I can give you specific tips and tricks to your environment. So I think that is really helpful because even though we have things like stairs and beds and tables that we try to replicate what you're having difficulty with, it is a lot more valuable to a patient if you can see their space and you can see the specific chair that bothers them when they sit. You can see their workspace setup. You can see their bed when they're getting in and out of beds. So that's been super helpful. But it is a little bit of a safety concern when they're older as well. And then last thing is it just makes them a little bit more accountable. When patients come into the clinic, they do rely heavily on your manual cues, your verbal, tactile things that you do to correct their movement. When they're on the other end of the computer, basically all I can do is try and tell them and wait until they figure it out or their body figures it out. So that muscle memory comes on a lot faster because I'm not there to sit there and be like, oh no, I mean, contract this muscle or move this way. I just have to describe it as best I can and wait until they get it. And then once they do, then they have it for life. But they do have to be a little bit more accountable and self-sufficient, which is good and bad depending on how you look at it. Okay, and I just had to find one other way to throw the love of my life in there. So that's Ryder again. I do take her into the clinic with me sometimes. She is definitely not a therapy dog, but she's therapeutic in some senses because she's the cutest thing ever and very friendly. These two Instagrams, the first one is my personal one. The second one is our company, IPT Miami, for integrated physical therapy. And the other thing that I started doing with the COVID was helping to run our IPT Miami page. So I pretty much knew nothing about, still probably know very little about social media, but I'm trying to learn and I'm trying to incorporate that as a little bit of side work and just trying to show patients different things that they didn't even know that they wanted to know. When they're after care or if they're considering coming in, it's a good way to try and reach out to get new patients in as well. So if you guys have any questions, throw them this way. And I don't know if I can see them.
We'll be asking the questions, Isaac and I. I just want to say thank you so much for that wonderful presentation. It was really insightful and I really enjoyed it. I'm sure all of our other students enjoyed it as well. So our first question is going to be from a student. This is sort of a little background, she said, or he, I'm not sure who said this, but I just switched to a pre-PT track this semester and had struggled with my GPA my first semester. How could I stand out with a low GPA?
Okay, so GPA definitely isn't everything. It is important. Your GRE scores are important, but I also think being a well-rounded student is something that, talking to staff and faculty later on, I found that they're really interested in. Being a straight A student doesn't mean anything, but being able to balance maybe having a job, it doesn't have to be anything crazy. I taught 3 hours of spin a week, but it was still some kind of job, and it gives you a well-rounded looking application because they see that not only are you sitting in class, everybody's doing that. Everybody's taking the same test, everybody's doing this, but what else can you balance? And, being involved in different clubs or different volunteer things, any opportunity that you can get where you show consistency. I wouldn't say just going in and, today I volunteered at the beach and next week I volunteered somewhere else, but just being a part of something where you can show commitment and a follow through, because that's what they really want to see.
Thank you. The next question asked was, why did you choose to go to Nova for your DPT program?
Such a good question. So, as insightful as I sound right now, I definitely was not. After I graduated from undergrad, I still didn't know that I wanted to be a physical therapist. And I actually missed the cutoff for almost every school that I wanted to apply for. So you should definitely start looking early and find when those cutoff dates are. It obviously worked out because it was a great experience, but I was only able to apply to 2 different schools. It was FIU and Nova Southeastern. I got into both, and I chose Nova just because it was a little bit better of a school at the time. FIU is definitely a great school, but I knew more about Nova, and it has a lot of different health professional fields and a very small campus. So the exposure to being able to take classes with other DO students, dental students, optometry students was something that I was really interested in, so that I could kind of get a little bit of all the worlds in one.
Thank you. So our next question is going to be more about your job. So this person is asking, could you speak a little bit more about the emotional/mental aspect of physical therapy?
Yeah, that's a huge part. And I know we definitely joke as physical therapists that we're not just physical therapists. We tend to be psychosocial therapists as well, because tissue and all those injuries, they get stored in your body. And to kind of just touch on that real quick, you have your fascial system, which is this 3D web that connects from your head all the way down to your feet, and there's no interruptions. It holds on to any kind of trauma that you've had, whether it's surgical, something you don't even know, sometimes it's emotional trauma. Sometimes we suppress those memories and they get stored in the body, and they can be released when we do manual releases. So somebody can, after, an ACL injury or something that maybe happened when they were 16, they can get these little like flashback moments of that same pain, even though it has nothing to do with their injury right now. It's just kind of that muscle memory, that fascial memory. And that can create, people cry, people laugh, people experience a lot of different things with us. So it is important that you get that bond with your patient so that they feel comfortable enough to have those experiences. I think holding on to the emotional component or that fear or that anything when you're going through recovery is something that can hinder your recovery. So being comfortable with your therapist and being able to cry when you have to and kind of let it out. It's not always because they're in pain. It's just all the things that are going on in their life. If you have a shoulder injury or you just had a shoulder surgery, now you can't work. That's super stressful. You can't take care of yourself the way you're used to. If you're used to being very independent and now you're relying on people for rides to therapy or brushing your hair, preparing your meals, all of those things really add up, and it can be very frustrating to deal with. Some people don't have a support system in place where, they have somebody living at home that can help them. If they're not married, if they don't have children, then they're very lonely. They're going through this crazy recovery by themselves. They're frustrated with their condition. And it can go one of two ways. They can come into the clinic and unleash it on you in a great way and bond with you, or they can take it out on you and you just have to learn not to take it personally. I will say a huge thing that we notice a lot is the day one patient versus the discharge day patient is not the same person. People come in with pain. They're angry at the world. They're not angry at you, but they do tend to take it out on you a lot. So you've got to toughen up your thick skin or whatever, and just make sure that you don't take it personally, because 6 weeks later, they're going to look back and be like, wow, I am so sorry that I was so awful to you on that day one, but it wasn't me. And I think that's important.
Thank you. The next question is, how did you financially support yourself for 3 years during PT school?
So I took out a lot of student loans. My job as a spinning instructor definitely did not cover the cost of PT school. I was fortunate enough to go to undergrad without any loans, so I didn't have anything from Florida State, but I still have loans, obviously, that I'm going to be paying back from Nova. So I did it all with financial help from the government.
Thank you. So our question next will be, what are some creative outlets? Oh my God, I'm so sorry. Everything just disappeared on me.
I'll take over if you want, Rose.
Yeah, sorry.
So the next question is, did you take a gap year between undergrad and DPT school? And what do you recommend as a timeline for someone interested in attending DPT school right after undergrad?
So I did take a gap year. I can't say that it was intentional. It was more or less that I just didn't realize that you had to apply for PT school or graduate school while I was in undergrad. My parents didn't. My dad went to college, but I was the first one to graduate. So even though we talked about things like going to college, it definitely wasn't something that I was well versed in. Even going from high school to undergrad, it just kind of happened. I didn't talk about it. I didn't do a lot of research. I applied for a couple of schools. I got into Florida State and I went. And with PT school, I missed that first round of deadlines, and then I almost missed the second one, and that's how I only got to apply to 2 schools. So definitely do your research early and make sure you get on top of that. Oh, and sorry, totally missed the second half of that question. So if you are going to go with a gap year, that is your time. If you're not 100% confident that you want to do physical therapy, but you know you want to work in something in the health and wellness field, then that's your time to try out a bunch of different things. That was when I worked as the scribe overnight. That was when I the exercise technician. So those kind of hands-on experiences where you're actually working and living the life, that's what the next 40 years of your life are going to be. So if you have to take 1 year to figure that out, then it's definitely worth it, because you don't want to end up in something that you don't love. If you do go straight into it, have to make sure to incorporate those hours during your undergraduate experience, because you don't have that gap year time to make up for it. So it will be a little bit more challenging to figure out timing of volunteering or shadowing at other clinics, but it's definitely possible. So many people do it.
Thank you for that. And sorry about earlier. I swear I muted my laptop. So the question is, I just had it. What are some creative outlets in order to get the shadowing requirements for PT schools for next year?
Now it might be a little bit trickier depending on where you are and the status of your state. For Florida, we definitely still have students, so it hasn't been as much of an issue in Miami area. But if you're somewhere where your state is a little bit more locked down, then you might have to reach out and see if a therapist is comfortable giving telehealth shadowing hours. So that's something that I've been talking about with my boss recently, because I have had people reach out through social media asking if they can shadow in on a telehealth session. And even though it sounds like, yeah, sure, why not? You do have to be mindful that nobody's recording, because there are going to be patients on the other end and you have to protect their privacy. So maybe they'll have something in the near future where they won't allow any kind of recording from other devices in the room or something like that. And it can be a little bit more proctored. But I imagine that we'll have to get some more hours virtually for those shadowing hours. But if not, you can reach out as long as you respect the social distancing requirements and wear your mask. Almost no clinic ever is going to turn down free help. So even if you just end up being the laundry and washer and note taker and whatever, you're still getting those hours. You're still getting that experience. It's super helpful for clinics because we were always overwhelmed and doing a lot. So it's a good way to kind of get your foot in the door, and they'll love you for it.
Thank you.
Mhm.
The next question is, could you give us some tips for preparing for interviews to fit for PT schools?
Yeah, depending on what your weakness is for your interviews. So, like I said, for me initially, it was just public speaking or speaking in general. The best thing you can do is put yourself out there into a situation where you are uncomfortable. Again, it's a little tricky nowadays because of COVID, but one of the things that I recommend that I also still do to this day is going on something like Eventbrite and finding those random events that people are hosting in your neighborhood. And don't go with somebody you know, because that's going to be your crutch, but sign up for an event, go sit next to a stranger, talk to them, and just have a normal conversation, something that makes you a little uncomfortable, but the more you do it, the easier it gets. The first couple of times it is absolutely awful and you're going to feel awful, and you probably won't talk to anybody if you are as nervous as I was in the beginning. But it's like anything else that takes practice. If you lift a weight a certain amount of times, you're eventually going to get stronger. If you put yourself in that situation, you're eventually going to get better at it. I did a lot of mock interviews too with family and friends. So you can look up common questions that they'll ask you in a very basic interview. Most places are going to throw in some weird question. Like I think at Nova, ours was something about like, what would your favorite animal, or what would you be if you could be your favorite animal or something. So they do try to make it not stressful. But they're always going to have that one question that you're like awkwardly not prepared for that kind of throws you off. But the general questions about why you're interested, your strengths, your weaknesses is pretty standard for an interview.
Thank you. So our next question would be, how would you differentiate a sports medicine clinic versus an orthopedic clinic? And then if so, this person is interested in sports PT, and what areas would she be or he be able to work in?
Okay, so there is a lot of overlap depending on where your sports PT kind of sits, because sports PT, I mean, I work with athletes all the time of all different ages. If you're planning on doing something specific, like you want to be a physical therapist that only treats golf players or only treats tennis players, which that definitely exists, and you'll be like a specialist in that particular sport, then you would have to go into either a team, or you can be in a regular outpatient setting, but you'll have your own clientele of patients that come in to see you from a certain sport. So it's basically going to be more on the referral side that people are going to be coming to you. Um, if you already know, sometimes people play sports their whole life and they got part-time job coaching. Like I had a couple of friends who did coaching on the side as a weekend thing or for younger athletes, and then that can be a good way to get your foot in the door so that you have that experience as a leader in that particular sport, and then you can kind of just carry it over into being a physical therapist in that sport.
Thank you. The next
Did I get
question is,
parts of that question?
yes.
Okay.
The next question is, are there any requirements in terms of examinations or education if you decide to work as a PT outside of the country?
There is definitely a difference between working in America or working outside of America. I don't know off the top of my head what those requirements are. I don't even really remember if there was like how we have our boards exam. I don't know if they have a boards exam. I'm sure they have something like that, but their curriculum is different in that they don't do the 4 years of undergrad and then the 3 years of grad school. They typically go straight into physical therapy programs as their undergraduate. So I'm not sure. Sorry.
It's okay. So could you speak more about your internship in Texas?
Yeah, very randomly specific, but sure. So I was also in an outpatient orthopedic center, so very similar to what I'm in right now. It was, again, all ages. I would say the majority or the most common outpatient orthopedic is going to be more in that like 35 to 65 age range. And that's just because pediatrics are going to always try and go pediatrics if it's close by. Geriatrics are going to go with somebody who specializes in geriatrics, or they're going to be in a SNF. But it was the same thing here, where we see anything from post-op, pre-op, chronic pain, acute pain, anything like that.
Thank you. The next question is, before COVID, did your workplace handle work hours differently?
Yeah, we didn't have to stagger. So all the therapists could be in the clinic at the same time. And we had all of our treatment tables set up on one side, and then we had our exercise stuff all on the other side of the gym. So when we were doing manual therapy or manual interventions, we were all together, and then, we could move around the gym based on what we needed. Now each therapist basically has like a corner of the room, and we have 2 treatment tables per therapist in that area. And then we have a piece of equipment where we can obviously walk over and use the other equipment, but we just try not to invade somebody's 6 feet. So we'll cycle around based on, we know the patient coming in and like, oh, I need the Pilates reformer for this hour. Can I have the treatment tables on that side? Or I need the Cybex or whatever it is. You'll try to plan accordingly to have what you need available for that patient. We also used to have an exercise technician that helped us out with the exercise portion, so that while we were doing manual interventions, we weren't trying to go back and forth, but that ended up being, another body in the gym, which if we have a student with a therapist, and then we have 2 patients, and then we have a exercise technician, like that's already 6 people, 5 people in a room that for one episode of care. So it just ends up being a lot. So we had to take that out as well.
Thank you. So this one's more about balancing everything. So how were you able to balance undergrad with taking the GRE shadowing volunteer and applications?
I feel like I kind of cheated because I had that gap year, so I didn't have that much to balance. I will say that the best thing you can do, and it sounds ridiculous, but is have a lot on your schedule. There's a saying that I swear by, that if you need something done, ask a busy person to do it. The more that you have, if you have a part-time job, if you have a volunteer or something, if your schedule is busy, you're going to find the time because you're going to put that time slot in and you're going to make it happen. If all you do is go to class, and that's why nobody's going to want to see your application of straight A's if all you did was go to class. I mean, if no offense, but if all you do is go to class and you can't get straight A's, like something's missing. So if you're getting decent grades, but you also have those extracurriculars or that other stuff involved, and that shows that you're a little bit more well-rounded, like we talked about, and you're able to balance and juggle, but you just have to designate the certain time for it. Look at the school that you're interested in applying in, see what the requirement is. If it's 10 hours, that's going to look a lot different than what you have to cram into your schedule if it's 80 to 100 hours. So every school is a little bit different. I don't even think that Nova at the time required hours, but it is going to make you more competitive. I would say at least having a minimum of 60 hours, which sounds like a lot, but just get it done. It happens.
Thank you. The next question is, do you recommend becoming a physical therapist technician in undergrad or just focus on doing shadowing work?
You have the benefit if you are a technician that you're getting paid, obviously. So it can be a part-time job for you. It's probably not going to pay your bills and make you a millionaire, but it can give you, gas money, food money, whatever, something extra on the side. So that would be the benefit definitely to having it as a job. The actual, when you're applying to PT school, do they care if you did it as a shadow, as a volunteer, as a job? Not really. So if you're scared of having the commitment of having a job, because obviously that's part of it, then go more on the volunteer side because you don't have to tell them, I'm going to be here from this day, this time. It can be a little bit more flexible.
Thank you.
Mm-hmm.
So this one's more about GPA again. What is usually the average GPA that you observe in applying for PT schools? And if you know anyone who was able to get into PT school with less than required GPA?
Yeah, so it's definitely been a while since I looked at the requirement, but I want to say the lowest probably a 3.2 that I know. That doesn't mean that somebody with a lower GPA didn't get in. That just means that I didn't know anybody who had a lower GPA. Your GPA, again, isn't everything, so don't stress too much about it. But going into your classes that are more challenging, if I can give you any tips and tricks, it's things like orgo or something like that, where people say it's impossible and it's so hard. It is definitely not. I am not good at chemistry. I'm not good at physics. I don't like it. None of those classes made me change my life. I want to be an organic chemist or a physicist. But a lot of times when there's a harder class that challenges your GPA, you tend to go into it with the mindset like, this is so hard, so I'm just going to not do it. But it needs to be the reverse. I knew organic chemistry was going to be one of those harder classes. So I took 2 hours every day and I studied organic chemistry and I got an A. So nothing's impossible. If your GPA is already a little bit low and you're worried about not being able to pick it up, you can, talk to your guidance counselors and tell them your choice or your path. They'll be able to pick out the schools that are realistic for you to get into. They'll be able to tell you what courses you can take to either override those grades so you can take classes again if you need to. You want to make sure that your science GPA is at least that 3.2. So if you're taking all elective classes, but your science classes are where your GPA is really lagging, they are going to look at your science GPA separately. So it's important to make sure that those classes, if you need to retake them, you have to retake them, do whatever you need to do, but keep that science GPA up.
Thank you.
Mm-hmm.
The next question is, did you participate in research during your undergrad career?
I did not. You definitely don't have to. And you also don't have to when you're in PT school, depending on the school. So there are schools that require you to do a research project. It was optional at Nova. I did something called a capstone project with the Special Olympics, which is modified research. It's not like anything crazy. There's no big presentation at the end unless you choose to do one. But a lot of schools will have you start with a project that you pick your first year and you take it all the way through your 3 years and you continue to work on that project. Nova was not one of them. That was a good reason. You asked me earlier why I picked Nova. That was one of the ones, and I forgot that you don't have to do research at Nova, and I was not interested in research. So
Thank you. So right now our question would be, can you speak about imposter syndrome?
So it's definitely not in my specialties. So I'm going to divert so that I don't say something incorrect about it. because I don't want to step on anybody's toes there. So sorry about that.
No worries. The next question is, what was the most memorable case you've had?
The most memorable. Well, it wasn't that the case was so memorable, but it was just the experience in general. Like I said, you do end up bonding a lot with your patients sometimes. So when I was a student, not even as an actual physical therapist, it was one of my internships, and I think it was my Texas internship. Yeah, it definitely was. It was my internship in Texas, and I had this little older man who I thought was just like the cutest thing of all time. And he was super sweet, super nice. His only real goal was just functional stuff like being able to get up and down from the floor and those kind of things that we really tend to take for granted. And the first day that he was able to get up from the floor, and like as a student, everything is really cool and amazing when you see a change. So his first day being able to get up from the floor, I definitely cried, and I cried a lot when he left as well. So I had a really good connection with that patient, and it wasn't anything crazy. I didn't have him going back and running marathons, but just being able to get down from standing to the floor and being able to stand back up, which is super important and overlooked, but it was super memorable for me.
Thank you. So we have one last question before we wrap up, and it would be, how often does information change in your field in terms of evaluation, diagnosis, or treatment?
So it depends on how you mean that question. If it's in regards to research and like what we know as a field, then that's literally changing every single day with every single person. Um, we try to stay as up to date as possible because it is super important that you are following the new trends and the new changes, even with orthopedics who refer to us. You know, some are a little bit older in their mindset. Nowadays, we don't use as much in the outpatient orthopedic setting of eSIM or ultrasound as a pain management. We'll use it as more of a last resort because there's not a lot of research that supports the efficacy of it. So that's something that's changed. When I was an exercise technician, I eSIM'd and ultrasound everybody, and I thought it was the greatest thing ever, and I thought it was magic. Now I realize it doesn't really do that much unless you have exhausted all other options. So that's something that, and if that's what the question meant, and if the question means in a particular plan of care, how often we update or change the plan of care, then that depends on the person too. If they're not compliant and not doing their stuff at home, then it's going to extend that plan of care or terminate it, because if you can't get somebody to be cooperative, then they're not going to get successful, and there's no point in continuing to see them and just kind of wasting everybody's time. But the diagnosis more than likely will not change. And even though there's a particular diagnosis, you're always going to treat the entire body. So you might have to look at the joint above or below and assess other things that aren't directly the neck. You might have to look at the shoulder or the elbow. You might have to look at the shoulder and the wrist or something like that. So you might have to add different things that you look at when you feel like you hit a wall with the body part that you're treating.
Thank you so much for this presentation. Our last question is, do you have any last advice you'd give pre-PT students or pre-health students in general?
Yeah, it's a morbid topic, I feel like, but student loans are something that you seriously have to consider and think about. Whatever career you want to go into, whether it's PT or something else, take a look at the average salary for the area where you want to practice and where you want to end up. And then also the cost per year of school. If you have parents or somebody who can help you out with finances, that puts you ahead of the game a huge amount. Even if they can just give you the money interest free, that's going to make a big difference. But realistically, the average salary for a physical therapist in my area is about 85 to 90,000 a year. And that doesn't mean first year, that's average among first year versus 20-year therapists. So you have to keep that in mind as well. But if you take out $200,000 in student loans and you're collecting interest on that and you're making 75 a year, then the career really just isn't going to pay off, and you'll be in a downward spiral of debt forever. So definitely just keeping in mind that if you do choose that career or that path, if you take a gap year, you're saving money, you're doing something to put towards it, or you're doing something smart, get a financial planner, someone to help you, because nipping it before it becomes a problem is going to eliminate a lot of stress later on. You don't want to graduate, feel like, oh, I have this amazing secure job that I've wanted my entire life, and then feel like you are never making money and you're just paying money to cyberspace forever.
Great. Thank you so much, Brittany, for joining us today. This was an amazing presentation, and we really got to learn so much more about what a physical therapist does on a daily basis. And so thank you so much. For all of my students joining us today, I'd like to direct your attention over to our wrap-up presentation. At the very end of this, I will go over how to get your verified shadowing hours via our post-shadowing assessment. So definitely stick around if you're interested in getting your certificate for today. My first announcement is really quickly, again, please help us keep our program alive. We love providing these opportunities for you guys. And we are really just trying to keep our website from crashing so everybody is able to take the post-shadowing assessment at the end of all of our sessions. This is a different QR code. This will take you to actually join our fundraising team. So rather to donate, this will allow you to join our team. And if you share with 15 people, you can actually get volunteer hours for this. So we offer verified volunteer hours. Be sure to share this, send in your screenshots, and we can definitely get you set up 100% remote. We're going to go ahead and skip this just because of the website load. We don't want it to crash. Normally, we would start doing reflections so that the students have an opportunity to take a moment to just reflect on what part of the session happened. So just be sure that you guys are doing your reflections with yourself so you can have something interesting to write about when you are applying to your programs in the future. Quick announcement, we are taking applications to join our student team. So if you're interested in gaining some leadership opportunities, meeting with like-minded students, gaining some professional experience, getting something great on your application during this global pandemic, definitely apply. We are taking students from all over, not only the US, but the world. We currently have students on our team from Canada and India. And so definitely apply if you're interested. If you feel that you don't have enough time to commit to pre-health shadowing, that is more than okay. We have volunteer opportunities open where you can work on your own time for as many hours or as little hours as you'd like. You guys can sign up on our website as well. And here's a QR code that will lead you directly to that. I have a challenge for you all today. Be sure to follow our Instagram to never miss a session with pre-health shadowing. And the challenge is to go to Dr. Brittany's page, post on our Instagram page, and comment her last name letter by letter in the comments. We will be picking one of the students who was able to get this in order successfully, and they could potentially be our student of the session. So good luck with this. It's very challenging, and I challenge you all to do that. Lastly, be sure to tag us at Pre-Health Shadowing in any of your posts. We really appreciate any reposts. Show your friends that you guys are participating in this great program. This is an opportunity for you guys to get your shadowing hours. So really just help us get the word out. Our goal is to make sure that every single pre-health student everywhere has the opportunity to join pre-health shadowing. Whether they join or not is up to them, but we just want to give them the opportunity to join. This is a free program. We are accessible. And so just letting people know about us is our ultimate goal right now. Our next shadowing session is tomorrow at 10:30 a.m. Pacific Standard Time. We will be shadowing a United Kingdom family practitioner. So it's really exciting. We'll get to learn a little bit about healthcare in a different country, which is going to be very insightful. So be sure to join us. We actually have shadowing sessions every day this week. So be sure to not miss out. And now, last but not least, to get your certificate, you are going to go to the www.prehealthshadowing.com website and find Dr. Brittany Inerfeld's page. Once you go to the course page, you are going to see a picture of her, and to the right of that picture is going to say free take this course. Once you get in there, you're going to see the quiz. You're going to have 30 minutes to take this post-shadowing assessment. You have 2 tries to get 70% or higher. Once you achieve that 70%, whether it be your first or second time, I encourage you to click finish course, on the certificate, it's not going to see what grade you got. So if you pass with a 70, it's the same as passing with 100%. So be sure if you get a 70 and you're trying to maybe get a higher score, just be sure that you save your certificate beforehand. Otherwise, your eligibility will go away if you do not pass the second time. Once you pass, go ahead and go back to the speakers page and click finish course. If you don't click finish course, you will not receive your certificate. So this is a crucial step. Once you click finish course, your certificate will be downloadable immediately and can always be found in your profile under the certificate tab. If you guys have any questions or experience any issues, feel free to email us at info@prehealthshadowing.com. Thank you all for joining us today, and that concludes our virtual shadowing session. You may now disconnect from the call.